Welcome back, everyone. Today, we are diving into the plumbing of the hand. We're talking about synovial sheaths and the ulnar and radial bursae. Dr. Sarah, I'm excited because this is where a tiny prick from a rose thorn on a finger can turn into a surgical emergency at the wrist in 24 hours.
It's a classic anatomical setup, Dr. Khan. For the boards, students have to visualize these as more than just names on a list. These are double-layered tubes of synovial membrane that wrap around the long flexor tendons as they pass through the carpal tunnel and into the fingers.
Right. I always tell my students to think of these sheaths like a balloon filled with a tiny bit of oil. If you take a piece of string, the tendon, and push it into the side of the balloon, the string gets wrapped in 2 layers of the balloon. It can now slide back and forth with 0 friction. But Sarah, why does this matter clinically? Why isn't it just one giant sac for all the tendons?
Precision and isolation. In the palm, we have the ulnar bursa and the radial bursa. The radial bursa specifically protects the tendon of the flexor pollicis longus, our thumb flexor. The ulnar bursa is much larger. It contains all 8 tendons of the flexor digitorum superficialis and profundus.
Okay, so the ulnar bursa is the big house for the 4 medial fingers. But there's a trap here, isn't there? A high-yield anatomical quirk that the boards love to test.
Exactly. Most people don't realize that the synovial sheaths for the index, middle, and ring fingers actually stop in the middle of the palm. They are closed-ended tubes. However, the sheath for the little finger is almost always continuous with that giant ulnar bursa in the wrist, and the thumb sheath is usually continuous with the radial bursa.
There it is. That is the express train to the forearm. If you get an infection in the middle finger, the pus is trapped in that local tube. It stays in the finger. But if you get an infection in the little finger, it doesn't stay there. It travels straight through that continuous ulnar bursa, under the flexor retinaculum, and into the wrist. Why does this matter clinically? Because you've just turned a finger problem into a compartment syndrome risk in the forearm.
And it gets even more dangerous. In about 50% of the population, the radial bursa and ulnar bursa communicate at the level of the wrist. This creates what we call a horseshoe abscess. An infection starts in the thumb, travels to the wrist, crosses over to the ulnar bursa, and then ends up in the pinky. It's a high-yield board favorite.
I've seen this in the ER. The patient looks like they have a standard hand infection, but when you look closely, both the thumb and the little finger are swollen and held in that classic semi-flexed position. Speaking of which, Sarah, how do we distinguish a synovial sheath infection from a simple skin infection? You have to be the doctor of choice for your patient and catch this early.
You're referring to Canavel's 4 cardinal signs. This is 100% board material. If you see these 4, it's tenosynovitis. First, the finger is held in slight flexion. Second, there is uniform sausage-like swelling of the entire digit. Third, there is intense pain on passive extension, trying to straighten that finger out. And fourth, there is exquisite tenderness along the entire length of the sheath.
That passive extension pain is the big one for me. It's like trying to pull on a wet sock that's glued to a slide. It's brutal for the patient. But let's go deeper. If the infection breaks out of these bursae, where does it go? The book mentions the space of Perona.
The space of Perona is a potential fascial space in the distal forearm, sitting deep to the flexor digitorum profundus and superficial to the pronator quadratus. If the ulnar or radial bursae rupture proximally, the infection floods into the space. It's the last stop before the infection starts climbing up the arm.
It's a terrifying progression. It highlights why hand anatomy isn't just about memorizing names, it's about mapping the roads that bacteria follow. If a student sees a patient with a puncture wound on the 5th digit, and the patient now has pain when you move their wrist, they should be thinking ulnar bursa immediately.
And don't forget the vincula, those tiny folds of synovial membrane that carry blood vessels to the tendons. If the pressure from an infection in the sheath gets too high, it squashes those vessels. The tendon loses its blood supply and literally dies, or necrosis. Then the patient loses hand function forever, even if you clear the infection.
That's why we say pus under pressure in the hand is a surgical emergency. You have to open those sheaths to save the tendons. Let's wrap this up for the students. What are the top 3 things they need to take to their exams?
1. The digital sheaths of the thumb and little finger are usually continuous with the radial and ulnar bursae in the wrist, respectively. 2. The middle 3 fingers have isolated, blind-ended sheaths. 3. Canavel signs are the gold standard for diagnosing tenosynovitis.
Perfect. Remember, the pinky and the thumb are the leaks in the system. An infection there is a direct line to the forearm. Thanks for the precision, Dr. Sarah.
Anytime, Dr. Khan. Stay sharp on those horseshoe abscesses, everyone.